I want to introduce, with a quick intro, Dr. David Katz. He is a physician of preventive medicine and public health, and he's a past president. By the way, he's the third president of the American College of Lifestyle Medicine that we've had present at this conference this week. Yeah, right? And he's the founder and president of True Health Initiative, the founder and CEO of DipIBLM, and he's also the co-author, or he's the author of How to Eat, a new book. So, Dr. Katz, welcome.
Thanks very much, Scott. Hi, folks. Had enough? Plants are good? Did you get the message? You are at risk of hearing more on that topic from me. Very good to be with you. And it is indeed a pleasure to meet a new group. Actually, just discussing with Scott Stahl, who's a dear friend, esteemed colleague, how much we like to go to places we haven't been. There's some potential opportunity to speak to a congregation that isn't our customary choir, and maybe actually exchange ideas that are novel. Very easy to keep going back to the same comfortable places. Everybody nods their head at you, but nobody's really learning all that much. The other thing, shout out to the organizers of this conference, looking over the agenda. I don't know how you've experienced it. I just got in last night, and I'm here briefly. It's a cameo. But I really like the juxtaposition of perspective from altitude, and frankly, that's my job, and the granular hands-on practicalities that seem to suffuse this conference. If it went as well as it looked in the brochure, it's a really well-structured program, so a lot about the what's going on and quite a bit about that, now what do we do with it in the clinics. I stopped seeing patients some years back. I actually left academic medicine a few years ago to become an entrepreneur. Spent most of my career at Yale, but I saw patients for 30 years. I was board certified in internal medicine, then did a second residency in preventive medicine, public health. So really appreciate that combination of practical granularity, view from altitude. I've hoped you've had an ample bolus of the former so that you're ready for a bit of the latter, because again, that's how I see my role. And then finally, just to acknowledge my colleagues, along with Dr. Stahl, Dr. Greger, Dr. Frades, others, very fine company to be in. I trust you've appreciated your interactions with them. And without further ado, as you enjoy your lunch, and by the way, impressive, another critical issue. Many of you go to medical conferences, various places around the country, national conferences, professional societies. How often do you notice that when it comes to chow time, they practice any of what they're preaching? The food, for example, at the American College of Cardiology Conference, notoriously dreadful. This is lovely. We can't just talk the talk, we have to walk the walk. So we're going to talk about the benefits of behaving a particular way, whether it's physical activity, something about the environment, or dietary composition when it comes to the chow line. Doing it is critically important. So another shout out to the folks who put this together. It's a lovely assembly of foods there. Pleasure to be here. Thank you. And I will try to make a 5-flavored case for food and lifestyle as medicine. My mission, as it was assigned to me, was to talk about the evidence for lifestyle medicine in general. And I'm happy to do that, and you'll decide at the end whether or not I have fulfilled that mission. But I do acknowledge at the start, my focus is preferentially nutrition. Partly, and I will make this case to the extent you haven't heard it already, because yes, it is arguably most important, although it's one element in a key ecosystem of behaviors. But also because it's where people are the most lost and the most confused, and where we need the greatest effort to achieve the requisite reality check. And I think, like most of you who went into medicine, we want to fix broken stuff. Tend to gravitate to where the stuff is broken and try to fix it. And nutrition drew me in accordingly. So the 5 flavors that we'll get through over the next little while together, and my thanks to Jamie for being as expeditious as he was with his comments. I'm sorry we didn't get to hear more about his organization. It sounds really important. But I appreciate the opportunity to get up here and get started. I want to talk about diet and lifestyle as they pertain to people. Our obvious focus is health professionals. But I also want to talk about the acute experience of the pandemic where there was a massive missed opportunity. And I don't know whether you've heard a lot about this or nothing about this or something in the middle, but we'll get into that. We've got to talk about the planet. And again, I don't know whether over the course of your discussions here in Ogden you've had significant focus on planetary health or not, but we can't ignore it. And I might as well take the opportunity right here in the preamble to say this. I presume those of you who are aware of what's going on down here sometimes lie awake at night worrying about it. But I also presume, based on my interactions with other colleagues at other conferences, that you may not talk about it much with your patients. Sort of feels like diabetes, hypertension, dyslipidemia, coronary disease, the slings and arrows of outrageous epidemiologic misfortune are your day job, and the plight of the planet is something you talk to your spouse about at night and worry about and lie awake at night. I disagree. And again, I'll reiterate this in the fullness of time. We have some hope, our patients have some hope of being healthy, vital people on a healthy, vital planet, or they have no hope, and we have no hope of being healthy, vital people. It is just one thing. So I submit to you, with whatever authority I may have, that it is our professional obligation as healthcare providers, health professionals, to address planetary health. I think in 2023, if we don't advocate passionately, frequently, at every opportunity for the health of the planet, as well as the health of the people, we're actually abdicating on what is arguably the critical rate-limiting issue for the health of the people. It is our job. Thank you. We'll also talk about profit, because ultimately, if we are to advance this mission, we have to deal with the business case for it. Alas, you all know that all too well, right? The business influence on the practice of medicine is massive and growing all the time, and there's a lot of upheaval in our profession as a result of that. But critical issue, models that can be sustained over time are models that can be paid for, and ideally models that generate revenue, at least for somebody. So we'll talk about that. And then finally, bring it to a close, talking about the promise of getting all of this right. So let's start with people, our patients, what brought us all into the profession that we chose, the reason everybody's here today. We wanted to fix what was broken in people's lives, add years to lives, add life to years. It's what we signed up for. It's the mission. Let's talk about that. There's an argument that the origins of lifestyle medicine, certainly food is medicine, which is much in the zeitgeist these days, go back a couple thousand years to Hippocrates. And indeed, assuming he's been translated appropriately from the Greek, that's true. I don't go back quite so far. I go back to the early days of my own career, just about 30 years. I finished my training in internal medicine in 1991, went directly to Yale to do a second residency in preventive medicine, public health, finished that in 1993, and within a matter of weeks of my graduation, this paper came out in the Journal of the American Medical Association. And I don't know if any of you has had this experience. I haven't heard too many colleagues say anything comparable. This one publication changed the trajectory of my career. Because I had gone on to a second residency to learn, in particular, clinical research methods. I was interested in postprandial lipemia. I was certainly already interested in lifestyle and dietary effects. But I thought to do what most clinical researchers do. I wanted to boldly go where no one had gone before, ask the formerly unasked question, probe for the elusive answers, work my way up to a Nobel Prize, that sort of thing. This paper changed all that. McGinnis and Faggy wrote this paper based on 1990 data published in 1993 called Actual Causes of Death in the United States. Anybody familiar with it? Admittedly, it's an old vintage. Okay, so I think you should be. Again, one guy's opinion, but I think this is arguably the most important peer-reviewed publication in the modern era of biomedical science. McGinnis and Faggy said, we get causes of death listed on death certificates, often produced by sleepy medical residents at 3 o'clock in the morning in a hospital. They just want to be done with the job and go back to the call room and try to get some sleep. So they're not terribly recondite. We're not getting a lot of information there. Somebody dies of congestive heart failure following an MI, cause of death was MI, and maybe it will go so far as to invoke atherosclerotic disease of the coronary arteries. But all of those answers are the same. Atherosclerosis, yeah, it's the proximal cause of the MI, which is the proximal cause of the heart failure, and somebody dies of cardiogenic shock, but all we really got is a pathology. But what we don't have is what caused the pathology. What gets listed on death certificates as cause of death is, in fact, generally an effect. And what McGinnis and Faggy did that was novel, and this grew out of the healthy people objective, so it followed in that pedigree, was ask, yeah, but what caused that? What was the underlying root cause of the atherosclerosis that caused the MI, that caused the heart failure, that caused the cardiogenic shock, that caused the death, and so on for everything else that populated death certificates. And when they were done, they had enumerated a list of 10 factors which collectively explained essentially all of the premature deaths that occur in the United States every year, but for a rounding error. And the list of 10 factors included some things that individual bodies could do to take better care of themselves, and some things that require action of the body politic, such as dealing with environmental toxins and highway safety and guns. But what captured my imagination as a newly minted preventive medicine specialist was the fact that 80% of the action was compressed into the first 3 entries on McGinnis and Faggy's list. And those first 3 entries were bad use of forks — this is actually pretty good use of a fork — feet, and fingers. And I've used that alliteration to sum this up ever since. Bad use of feet, forks, and fingers. In other words, lack of physical activity, poor dietary pattern, and bringing toxins like tobacco to our lips. So this is bad use of fingers right here. Everybody got that? That's the motion. So that was bad. And in fact, tobacco was number 1. It was the leading cause of premature death in the United States in 1990. 80% of premature death and chronic disease in the nation were ultimately attributed to these 3 root causes, suggesting that if everybody didn't smoke, ate well, and were physically active, 80% of chronic disease and premature death would go away. Well, that changed my career. Basically because what is the rationale for asking the next unasked question when the answers we already have lying fallow could eliminate 80% of chronic disease and premature death? And I decided essentially right then and there, my entire career has to be about turning knowledge into the power of routine action. If I can add incrementally to the knowledge we have, great, but the knowledge we have and aren't using is enough to eliminate 80% of chronic disease. And by the way, I think it's useful to acknowledge the extent to which we all have skin in the game. So talking to a room full mostly of docs, but other health professionals, we all care for people who have all of these conditions: heart disease, cancer, stroke, diabetes, dementia. But we all know it goes deeper than that. Forget about your patients, forget about what you do professionally. Let's just talk family. Let's talk about skin literally in the game. How many of you love somebody who has been affected by heart disease? Show of hands. How many of you love somebody who's been affected by cancer, diabetes, stroke, dementia? If you put your hand up at any time, put your hand up now, and let's just look around the room. Everybody. Everybody. All right? So, and I just listed the top 4 or 5 chronic conditions in modern epidemiology. They've invaded our homes and our families. It's not just about what we do professionally. This is up close and personal. It's an intimate experience. So now imagine, again, not just in terms of professional achievement, but personal fulfillment, a world where 8 times in 10 you didn't put your hand up because 80% of chronic disease had gone away. We've been sitting on the promise of that for 30 years. And I've been trying to do what I can to advance that promise. Not with great success, I readily admit. I was talking to Scott Stahl in the back of the room about how hard we've been working for how long and how little there is to show for it. And we do all have to wrestle with that. More obesity than when I started out as an idealistic young guy who thought he could bend the curve. More chronic disease at ever younger age than when I started out. My friends, we should not delude ourselves. We're not winning the war. We have miles to go before we sleep, if ever we are to fill the promise of all this. Okay, so 30 years ago, my career changed because of this paper. And it's important then not to rely too much on just one publication, but it's really not just one publication. This issue was reanalyzed 10 years later by a group at CDC, including then CDC Director Julie Gerberding. They analyzed the same massive database and reached substantially the same conclusion. All that had really changed over the span of that initial decade is that the gap between tobacco as the #1 cause of premature death and the combination of bad use of feet and forks as #2 had narrowed. It had narrowed for the good reason that we were smoking rather less, but also the bad reason that diet quality continued to deteriorate or at best stagnate, and physical activities did much the same. So we were not active enough, we weren't eating well, thank goodness we were smoking a bit less, but feet, forks, and fingers remained the leading causes of premature death and chronic disease. Now that's a bit gloomy, so it begs the question, what's on the other side of the coin? Can we flip this around and tell a happy story? And it turns out we can, not just once, but over and over again, a veritable drumbeat in the peer-reviewed literature. But here's one example I particularly like. Earl Ford, colleagues at the CDC, did a nested observational study within the EPIC study of cancer throughout Europe. They examined 4 factors among 23,000 adults in and around Potsdam, Germany. They asked these people, do you smoke, yes or no? Are you physically active on a regular basis, yes or no? Do you eat well, yes or no? And you might think that would be a very erudite formulation that would need to get into the weeds of glycemic load and sirtuins and lectins, but not so. They simply defined eating well as habitual intake of vegetables, fruits, and whole grains, and it was enough. And they asked a 4th question, do you have a healthy weight? Important to note, I trust you're all sensitive to this issue, one of these things is not quite like the others, and you could even argue that one of these things maybe doesn't quite belong, because 3 of these are behaviors. You can decide whether or not to smoke, you can decide what you're eating, and you can decide whether or not to move your feet, but did anybody wake up and decide what to weigh today? Would that it were so, right? Weight is not a behavior. Weight is not a choice, weight is an outcome. And it's an outcome only partially subject to volition and choice, because it's also subject to resting energy expenditure, metabolic factors, the influence of our microbiome composition, possibly viral exposures. Most of those are relatively modest compared to use of feet and forks, but by no means trivial, and it's absolutely true. If any of you doubts this with your patients, permit me to offer the reality check. It's absolutely true 2 people can eat the same, exercise the same, one gets fat, one stays thin. It's not fair, but it happens. But critical for us to recognize, and critical also for the payment side of medicine, which is dealing in behavioral economics and incentivizing healthy behaviors, to recognize that weight is not a behavior. We should not incentivize a healthy BMI. It's silly. It's like incentivizing not having emphysema. People don't decide whether or not to have emphysema, but they can decide whether or not they're exposing their lungs to toxins. We should direct our efforts, incentives, disincentives, behavioral economics to behaviors. But I digress. Back to Potsdam. So 23,000 adults in and around Potsdam, Germany, answered 4 questions. Do you smoke, yes or no? And what the researchers then did, do you smoke, yes or no? Do you eat well? Are you physically active? Do you have a healthy weight? The researchers went on to compare the 2 extremes. So they compared, I don't smoke, I eat well, I'm physically active, my weight's fine, to I smoke, don't eat so well, I'm not active, my weight's not so good. These people, over a multi-year span of observation, had an 80% lesser incidence of all major chronic disease than these people. In other words, less heart disease, cancer, stroke, diabetes, dementia, all of that developed over the multi-year span of the study. Flip the switch from bad to good on any one of these factors, and as best we can tell, the lifetime probability of any major chronic disease goes down by as much as 50%. But combine the 4, there's an 80% reduction in, we believe, the lifetime risk, certainly the multi-year risk of any major chronic disease. Entirely concordant with the findings of McGinnis and Figi, but on the other side of the coin. If we get it wrong, leading cause of premature death and chronic disease. If we get it right, leading opportunity to add years to life and life to years. And we know a lot now in the years that have ensued since about the mechanisms of all this, the intracellular, physiologic, metabolic mechanisms. Because the impact of lifestyle reverberates to our innermost cells, to within the double helix of DNA. I heard Dr. Stahl mentioning Dr. Ornish's work. I invoke it again. Dean's a good friend and has done perhaps more than any one person to demonstrate what lifestyle can do in multiple domains. His current focus is Alzheimer's. I know he'll be presenting on his research in that area at the American College of Lifestyle Medicine meeting coming up in the fall. But in this instance, he turned his attention to cancer. And they did a study of 30 men with early-stage prostate cancer amenable to watchful waiting. But rather than just watch, wait, and hope that the cancer didn't progress, they offered lifestyle as medicine. And they did a comprehensive, fairly intensive program where folks got an optimal plant-based dietary pattern, routine physical activity, obviously no tobacco or alcohol, or certainly not an excess of alcohol, so good use of feet, forks, and fingers. They then also addressed sleep, quantity and quality, stress, making sure people didn't have too much of that, so they did mindfulness, relaxation, so forth. And what I think Dean would tend to call, and what I'm happy to call, love, social connection. So they created a sense of community. Feet, forks, fingers, sleep, stress, and love. 6-cylinder engine of lifestyle as medicine. You get those 6 things right, after that, everything is vanishingly less important for the most part. They got all 6 right, and over the span of some months, they studied not so much the men, and not so much the cancer in the men, but preferentially the genes in the men with the cancer. And what they found is that the lifestyle intervention took 500 cancer promoter genes and dramatically downregulated their expression, and 50 cancer suppressor genes shown here and dramatically upregulated their expression. Left is before, right is after, red is off, green is on. So these genes were turned on. These are cancer suppressor genes turned on by this lifestyle intervention. Now, I would tend to argue diet probably had the greatest influence of that cluster, but it was the whole cluster. And that's really part of my mission here today. Despite the preferential focus on nutrition, we can acknowledge that all of these factors are critically important. And by the way, just a brief digression while we're looking at this screenshot of slides, we can acknowledge the interaction. It may seem, and maybe we can revisit this in the Q&A, because if you're in the trenches taking care of patients, you don't have enough time to take care of them, and they don't have enough time to take care of themselves, right? So you give them this laundry list of stuff they're supposed to do every day. They're too busy as it is, and everybody's thinking, can't get it done. I can't get done the counseling I'm supposed to do. I don't have time. I'm too busy. They couldn't do all these behaviors because they're stressed out and they're too busy. And it does sound like a long list: feet, forks, fingers, sleep, stress, love, if one were obligated to address them independently, but you're not. Because if you're physically active as opposed to not, you tend to sleep better. If you sleep better and are physically active, it affects your psychology in ways that makes a whole bunch of other stuff easier, like managing stress, forming good social connections, and moderating your dietary choices. Because actually the endocrinopathy of sleep deprivation compromises dietary choice in a wide variety of ways, and further compromises the metabolic fate of whatever it is we do eat. Physical activity can be a really great way of managing stress. I've got dogs, I live near the woods, and I'm an equestrian. I've tried to meditate. I actually know Deepak Chopra, and Deepak tried to get me to meditate. I cannot meditate. Every damn time I've tried to meditate, I find myself thinking this: how many emails could I be answering now? And I just can't get out of that headspace. But what I can do is go for a hike, work out hard, ride my horse. I'm privileged to have a horse, too, actually. But that's my meditation. It works. So my physical active time and my relaxation meditation, it's the same time. I double dip. I don't have to do twice. And then that helps me sleep better, which otherwise I wouldn't be too good at doing. And round we go. You get the idea. So it's really not just each of these in isolation, but each of these servicing the others. So I really like these comprehensive programs. It is a challenge, by the way, for those of us who are well-trained researchers in lifestyle medicine, because with RCTs, we like attribution, right? Why happened? Why did Y happen? We want to know that it was X and nothing but X. If you do a comprehensive lifestyle intervention, was it the diet? Was it the physical activity? Was it the stress, the sleep, the social connections? Was it the avoidance of toxins? All we can really say for sure is yes. We have a difficulty finding the active ingredient in a healthy lifestyle because it may be all of the above. Other studies, of course, have isolated these to some extent. This study, by the way, looking at impact on gene expression is by no means a standalone. There's a whole literature on this topic. It keeps growing all the time. And this pertains to a wide array of cancers now. So the issue is the debate about nature and nurture is obsolete. We now know that we can nurture nature. We can't change the genetic hand we've been dealt, but we certainly can change what those genes wind up doing. And there's more evidence of this that pertains not so much to the direct assessment of genetic activity per se, but indirectly via the epigenome. And I trust, as you all know, 95% of our chromosomal real estate is not genes. We used to think it was junk DNA, but we were wrong. It's the epigenome. It's levers and switches that basically determine what the genes we have do. 95%. So the bulk of our chromosomes is the epigenome. Epigenetic settings are influenced over generations because our mother's epigenome was set in the womb of a maternal grandmother, right? Because her eggs were fully formed inside her ovaries in utero, so there's a multi-generational effect. Our maternal grandmother's lifestyle has implications for the innate settings of our epigenome. Little disconcerting in some ways, but also a tremendous opportunity to have good health reverberate through the generations. But more importantly than that for all of us is the knowledge that we can change epigenetic settings with our behavior. That's well established. So when we change what we do, it changes the levers and switches, which in turn changes what our genes do. So that's what this study was about a few years back in the New England Journal. It looked preferential. And by the way, you will note, because I saw just a little bit of the previous speaker slides, lots of charts and graphs and charts and graphs. You'll forgive me. I don't tend to do the chart and graph thing. I think I've got one that's an eye test. I don't tend to do it because I've been in your seats for 35 years. I know what it does to the human mind to look at charts and graphs and try. I don't care if you're a scientist. I don't care if you're a Nobel laureate. It is soporific. All you want to do is doze off. So anyway, I don't tend to do it. I just talk at a high level. But you want the papers, I'm happy to share them. In any event, this study looked at people at genetically high risk for bad cardiac outcomes and found that a lifestyle intervention, all the usual stuff, slashed that risk in half. So bad genetic hand dramatically improved outcomes anyway, presumably mediated via the epigenetic influence on gene expression. And talking about chromosomal architecture makes us think about telomeres and chromosomal structure, and you're all familiar with telomeres, the caps, kind of like those plastic caps at the end of our shoelaces that protect the ends of our chromosomes, prevent them from unraveling. And we've all heard that long telomeres, other things being equal, are associated with long, healthy life. The other things being equal caveat is important. You can have long telomeres, still a really bad idea to stand in front of moving buses and trains, for instance, but other things being equal, long telomeres, long, healthy life. And in research associated with a Nobel Prize in Medicine for Elizabeth Blackburn at UCSF, it's been shown that these same lifestyle interventions lengthen telomeres, alter the activity of telomerase and lengthen telomeres. So you actually can grow your telomeres. And why does all this matter? I mean, you could argue in some ways it doesn't, except that we've all been trained in a reductionistic science. We don't want to just know what, we want to know why. When we know why, we're more confident. I think we do a more effective job at selling to one another. We have real conviction when we know not just what we think is going on, but we can explain why it happened. These intracellular, intra-DNA, intrachromosomal mechanisms give us the why. They don't really change what we know about the outcomes. People who get lifestyle right live long, prosper with vitality, and ultimately go gentle into that good night. It doesn't change, but we know a lot more about mechanisms than we once did. So this is really important. However, there was a recent paper in the New England Journal. This may have caught your attention, if only because it was picked up, I believe, by Gina Collada in the New York Times, questioning the advantage of long telomeres. This is the first I'd heard about this. By the way, there's a really good book that looks at the topic of lifestyle medicine through the lens of telomerase and telomeres called The Telomere Effect by Elizabeth Blackburn and her colleague Alyssa Pell. And that's a pop culture book. So if you're interested in reading an engaging story about what we know regarding telomere length and how we know it, The Telomere Effect. Anyway, this paper found that there is a cluster of genetic mutations, the POT1 complex, that are associated both with long telomeres and with not so good health outcomes. The New York Times picked this up and said long telomeres not so fast, maybe they're not good for you after all. But I think that's wrong. I think if you lengthen telomeres with lifestyle intervention, it's good. It's associated with long, healthy life. It's one of those intracellular mechanisms of longevity and vitality. If you have a genetic predisposition for long telomeres, that is also a genetic predisposition for an increased risk of select neoplasms, and that's what they found in this paper, then you are at increased risk for those neoplasms, probably because these genes travel together. I think that's what it means. It's a pretty dense paper. Did anybody happen to read this paper? It's a hell of a slog. But anybody who gets to the New England Journal may have seen it and thought, okay, interesting. I wonder if we've got doubts now about long telomeres. I don't think we do. I think the question is how you get there from here. Just as you can have a very high HDL genetically, and you may not be protected against coronary disease, whereas if you elevate your HDL by means of lifestyle, almost invariably you're reducing your risk of coronary disease. I think it's probably a similar association. Anyway, interesting paper. The other thing that has our patients preoccupied, it's much in pop culture discussions these days, is the issue of the microbiome. I don't know if you've gotten this question, but I certainly have. Do I now need to eat to feed my microbiome? Because it's so important. I keep hearing I can't be healthy unless I have a healthy microbiome. And of course, the answer to that question is in a way yes, but in a way no, because it's a silly question. Have you ever advised your patients on eating to have a healthy left adrenal gland, a right kidney, a left elbow, the right nary? You know, I mean, there certainly is pop culture interest in all that nonsense too, right? What do you eat to have a healthy brain, to have glowing skin, to have lustrous hair? I mean, the beauty magazines are replete with what you should eat for this organ. But we all know that the shin bone's connected to the ankle bone. That was in med school somewhere. And frankly, if we take good care of ourselves, everything about us is healthy and it's working in unison. It's very hard to isolate the parts, and the simple fact is the microbiome is a part of us. It's a critical part. And it's new knowledge, the sense that it doesn't just take a village to raise a human being, it takes a village to be a human being. That's fairly new. But it just stands to reason that what was good for us all along, what produced people who had longevity and vitality, must have been good for their microbiome. Because don't tend to be healthy if your microbiome's not happy. But you don't need to eat differently to feed the microbiome. So this paper in AJCN looked at that issue, healthy food choices, gut microbiota, and the conclusion was this. SCFAs, of course, are short-chain fatty acids. But we can distill this down to a quick punchline and say what it really means is this: what's good for us diet-wise is good for our microbiome and vice versa. I think Dr. Stahl was talking about TMAO. I presume you heard some of the detailed mechanistic pathways with the microbiome. I won't get into that. This is really what matters. This is the view from altitude. And by the way, I fully respect that I'm talking to a room full of colleagues and that I could get into the weeds here and you'd be right there with me. But ultimately, we want to translate this into the practicalities of better care for our patients. So it's nice to know that it's really a very simple message. All these mechanisms get pretty recondite pretty fast, but they're all telling the same basic story. A short cluster of behaviors has an outsized influence on every human health outcome that matters. And ultimately, the two that matter most: years in life, life in years, vitality and longevity. And so being able to rally around that message makes all of this much more actionable than it would be if we really needed to get into the weeds and try to manage that with our patients. We don't. I've done that, by the way, in various efforts. I've written 4 editions of a nutrition textbook, Nutrition and Clinical Practice, 850 pages, 20,000 citations. We've gotten into the weeds. But the high-level conclusions are delightfully simple, clear, and actionable. And they were distilled down, with regard to food anyway, to 7 words by Michael Pollan. Michael Pollan fans in the room? Gotta be, yeah. So obviously pithy, wise guy, and great at expressing himself. Eat food, not too much, mostly plants. That does sum it up pretty well. Now, again, I've delved into this across the expanse of 4 editions of a nutrition textbook. I also did this commission paper, Annual Reviews in Public Health in 2014. The editors asked me, they gave me the title of this paper and said, answer the question. Can we say what diet is best for health? So I was not nearly as succinct as Michael. It took me 5,000 words and a bunch of charts and graphs, but I reached the same conclusion. the fundamental theme of feeding Homo sapiens well is indeed a diet made up mostly of vegetables, fruits, whole grains, beans, lentils, nuts, and seeds, and plain water when thirsty. And you can delete from that list anything you're allergic to or sensitive to and so forth. But that's the gist of it. Fundamental theme. It should not disturb you that there is a fundamental theme. It should disturb us to think otherwise. Because after all, we're cousins. We're a kind of animal. I think in unique Homo sapien hubris, we tend to overlook that, and we seem to be okay with the idea that when it comes time to feed any other kind of animal, all we really need to know is what kind of animal they are. And for that matter, every wild animal, as best we can tell, has no real ambivalence about how to feed itself, unless we put them in captivity and confuse the hell out of them. But to the best of my knowledge, the lions on the savannah don't get together and say, I'm kind of tired of hunting. The wildebeest seem to be doing fine with grass. Maybe we can eat grass. Let's try the grass. And the wildebeest don't say, let's turn the table here. Tired of running from the lions. Let's gang up, beat them up, and see if we can eat them. Doesn't happen. It doesn't happen because of physiology, metabolism, and adaptation. The wildebeest are herbivores. The lions are carnivores. We happen to be omnivores. But getting diet right doesn't begin with RCTs, meta-analyses, and systematic reviews. Getting diet right begins with evolutionary biology and the fundamentals of adaptation, and that pertains to every species, including ours. So it should come as no surprise. There is a basic theme of feeding our kind of animal well. It's not negotiable. What is negotiable is the specific variant on the theme that will work best for you or someone you love or your patient, and we have a lot of latitude there. And that's where people get way too far out over their skis and argue that my diet can beat everybody else's diet. My specific prescriptive diet is better than her specific prescriptive diet, that sort of thing. Most of that is salesmanship. Some of it's overt nonsense, but most of it's salesmanship. But the basic theme, not negotiable. Mostly vegetables, fruits, whole grains, beans, lentils, nuts, and seeds, and plain water for thirst. If you really mostly did that, or some approximation thereof, you couldn't go too far wrong. And unless you mostly do that, almost everything else you do is apt to be rather off the mark. And I've conducted and published a number of RCTs and conducted and published meta-analyses, and I guess that's the sort of stuff that gets you up here at the podium in front of a great audience like this. But frankly, I think the evidence that matters most is what happens to entire populations of people over spans of time not conducive to RCTs. We've never randomly assigned 100,000 pregnant women to an optimal paleo or an optimal vegan diet and then followed their offspring for 80 to 100 years to see who lives the longest and best. And I don't think that study's coming anytime soon either, do you? So the answers to the questions we really want in lifestyle medicine, what adds the most years to life, life to years, cannot be derived preferentially, certainly not exclusively from RCTs. So I like ethnography, I like observational epidemiology, and I particularly like the blue zones, courteous of Dan Buettner, National Geographic fellow, who identified with the team at National Geographic those populations around the world where people most routinely live to be 100, don't get chronic disease, and die peacefully in their sleep at the age of 102. So as referenced before, they live long, they prosper with vitality, they go gentle into that good night in the fullness of time. Who can think of a better deal than that? It's as good as it gets. So the question is, what do? Well, frankly, they fire on all 6 cylinders, feet, forks, fingers, sleep, stress, and love, every time. And these are very diverse populations, by the way. The 5 identified blue zones, and who knows, maybe Dan's out there looking for more. The 5 are in Ikaria, Greece, Sardinia, Italy, so 2 Mediterranean populations. Okinawa, Japan, an Asian population. Loma Linda, California, among the Seventh-day Adventists. And on the Nicoya Peninsula in Costa Rica, which has a distinctly different dietary composition lifestyle from all the others. So quite diverse, genetically diverse, ethnically diverse, behaviorally diverse, but they all adhere to the same basic theme. They get feet, forks, fingers, sleep, stress, and love right. And what they do with diet can be put on this simple line gradient. If we think about animal food predominant and ultra-processed food predominant diets in red to the left as one end of the spectrum, and plant food predominant, real food predominant, in other words, Michael Pollan's advice, eat food, real food, in other words, whole food, minimally processed food, mostly plants. To the right, all 5 blue zones, as distinctive as they are, cluster right there. their diets are all like this. That evidence really matters because this is transgenerational. This is culture-wide. This is what happens to a whole population. I taught biostatistics for many years to Yale medical students and have written textbooks on that topic too. All we're really trying to do with biostatistics is to approximate what would be true if everybody were exposed. What's the truth in the real world? Statistical confidence, confidence intervals, p-values, it's all an effort to guess at that. Well, when you have that answer, here's what happened to an entire population of people over multiple generations, you're really beyond the realm of what you even need statistics for. So I think this is very powerful evidence. And again, that was my mission, was to talk about the evidence for lifestyle medicine. But there's another critical message that comes out of the Blue Zone experience, and that is people are not saying, my doctor is great. That's why I'm a Blue Zonian. My doctor's doing a really swell job with me. They're not saying that. My health coach, my dietitian. They're not seeing doctors. They have almost no interaction with what we would refer to as the healthcare system, and which, as we all know, is mostly a disease care system. It's not that. It's culture. Just normal in their society to eat real food, mostly plants, to be physically active, to avoid toxins like tobacco, to get enough sleep, to not be stressed out, and to have a strong sense of community. They're beneficiaries of cultural advantages. If we want lifestyle as medicine to go down, there's only so much I think we can do as clinicians. So again, I appreciate the practical focus of this conference. I think it's excellent. But we are also citizens of the world, and America runs on Dunkin'. Multicolored marshmallows are part of every 6-year-old's complete breakfast in our culture. And then we wonder about rampant childhood obesity and type 2 diabetes, which, by the way, when I was in training, we still called adult onset diabetes because it hadn't migrated down the age curve to become a pediatric scourge just yet. That happened on our watch. All right, so should we really be in the business of patching together with drugs and surgery stuff that our society is actively causing for profit as we gaze on and do nothing about the cause? There's a slide that preventive medicine specialists often show of a flooding room because of a sink that's overflowing, and a couple folks are busy mopping up the floor, but nobody turns off the faucet. That's what this is like. Got to turn off the faucet. So lifestyle is the very best of medicine. It's the only medicine we've got that can add years to life and life to years. But we need a spoon to help the medicine go down. Lord knows the last thing we need is more spoons full of sugar, but we need some kind of big spoon, and I would argue that's culture. Culture delivers lifestyle medicine more effectively than clinics. And this is not instead of what you do. And by the way, this is a reprise of my mantra, my platform, when I was president of the American College of Lifestyle Medicine. Basically, I told my colleagues, I appreciate what we're all doing as clinicians, lifestyle in medicine. But until we're in the business of cultural revolution and lifestyle as medicine, so it's actually the default to eat well, to be active, to not be stressed out, to get enough sleep. Till that reverberates through our culture, there's a limit to the progress we'll make. Nowhere in the world, to the best of my knowledge, has there ever been a case where an entire population was healthy despite their culture because their doctors were so damn good. Never happened. We just can't be that good. It's too much to ask of us. We cannot be anti-culturalists and expect the clinic to prevail. We can help individuals, and we do that. We empower individuals to overcome the challenges of what's all around them, but we should be in the business of fixing what's all around them. Lifestyle is the medicine. Culture is the big spoon. Clinics are an important spoon. And when we get into the issue of culture and think about America, we have to recognize we're not going to be a blue zone. We're certainly not going to be just one blue zone. We have a blue zone in Loma Linda, but we're not going to be a blue zone because what is everybody in America going to adopt the Okinawan diet or the Costa Rican diet or the Sardinian diet? I mean, it's very unlikely. What about the fact that we're multicultural? How are we going to deal with that? So if we want culture to mediate health, we have to do that in a multicultural way, meet people where they are. But that absolutely can be done, and this is where the issue of having a basic theme of optimal eating, but many variants on the theme, empowers us and empowers our patients. Now, because of the proprieties of CME, the last thing on earth I'm allowed to talk about is what I actually do these days, so I won't. But I will note that in this thing that must not be named that I do these days, we're working on a brand new way to assess diet and help people eat better. And one of the things we had to do was take a wide variety of diets and stratify them all into 10 tiers of quality using an objective measure. We used the Healthy Eating Index 2015, which is correlated against all-cause mortality and other important stuff. And what we found is we could take all the ethnic diets that prevail in this country and do that. My team of dietitians could build an optimal, top-tier version of South Asian and Chinese American and Cuban American and Mexican American. So when we've got a patient who's trying to manage their hypertension or avoid type 2 diabetes, we could direct them to the DASH diet and they could look at that and say, nothing I eat there. We could direct them to the DPP and they could say the same. Or we could say, okay, we want to basically find the confluence between the fundamentals of the dietary pattern we know are therapeutic and the way you're actually inclined to eat, which may be ethnic. So you've got a Mexican-American patient, you give them an optimized version of a Mexican-American diet. Totally doable. And I think that's one of the next great advances in public health nutrition. This is personalized nutrition, recognizing that there are variants on the theme of optimal eating. They can be rooted in heritage and culture. And anybody who wants to know more about exactly what we're doing with this in what I do, which I must not talk about, we can talk about it in the Q&A, or you'll find me after. But anyway, this can be done. It's really important. And then I mentioned that we're not winning the war, and that is a frustration. I try, particularly when I'm given a beautiful opportunity like this to speak to colleagues, I want to be enthusiastic. I want to be optimistic. But the simple fact is I've been doing what I do for the better part of 40 years. And as noted, what used to be adult onset diabetes is now type 2 and happens to kids. Obesity was already bad and it's only gotten worse. Chronic disease is more prevalent than when I started and happens at every younger age, to say nothing of what we're doing to the planet, which I'll say something about momentarily. But this critical issue that altered my career remains with us. Knowledge is only power if we translate it into routine action. And the challenge before all of us can no longer be wondering about what we know and don't know, because these fundamental truths of lifestyle medicine have been replicated over and over again like a drumbeat for 30 years. And they've been replicated in new ways, looking at different mechanisms, whatever window we look through into the intimacies of human function. We find new ways of saying eating well, being active, not smoking, sleeping enough, managing stress, strong social connections is really, really good for the human condition. Period, full stop, not subject to debate. What the hell are we going to do about it? What are the more effective models to achieve uptake of this at the scale of our entire population, or at least at the scale of our patient population? We all need to be in that game. Knowledge is not power if we don't translate it into routine action. And for these 30 years and more, we really have not. And so obesity continues to get worse, and not just in the United States, but all around the world. And obesity is an important topic in its own right, but obesity really isn't the critical issue. It's the diet quality that's fueling obesity. We all had, and I'm sure everybody remembers this acutely, we had an acute moment of silence and mourning and reflection when SARS-CoV-2 took over 500,000 lives in the United States. This op-ed in the New York Times predates the pandemic. It was August 26, 2019, so just by a matter of months before SARS-CoV-2 found us. Dariush Mozaffarian, Dean of Nutrition at Tufts, and Dan Glickman, former Secretary of Agriculture, wrote this op-ed in the New York Times, "Our food is killing too many of us." And they noted that poor diet quality, not hunger, not food insecurity, poor diet quality, junk where food ought to be, was killing more than 500,000 Americans prematurely every year. Every year. Moment of silence? National reflection? Mourning? No, it hides in plain sight. It's a slow motion, non-exotic epidemic, and in fact pandemic we take entirely for granted. 500,000 premature deaths every year. So this is what's happened during this span where we've known what diet could do for good. This is what it's doing for ill, and we have effectively exported junk where food ought to be, so that in the Global Burden of Disease study, this is now true in dozens and dozens of industrialized countries around the world. Poor diet quality, So remember where we started, right? I was newly minted preventive medicine specialist. That paper came out, actual causes of death. Diet was in the top 3 causes of premature death, chronic disease. Jump forward to now, 30 years later. Diet is not in the top 3 causes of premature death and chronic disease. Diet is the top cause of premature death and chronic disease. And again, a little bit of good news in the mix because we're smoking even less now. But basically, diet is so badly broken. Diet quality measured objectively is the single leading predictor variable for premature death in the United States today, full stop. That's where we are. And this was relevant acutely during the pandemic. The longitudinal relevance of this is obviously clear, but it has acute relevance, and this was, I think, systematically ignored. So colleagues and I weighed in early. We published a couple of papers in Emerging Infectious Disease where we looked at what we knew based on data out of, to some extent, Wuhan, but mostly Seoul, where they did a great job of assessing who was positive for COVID very early. They actually did testing in 200,000 people in a 48-hour period in Seoul. It was remarkable. And they were consequently reporting, okay, we know everybody who's positive, so we know who's getting really sick and who's not. And what they were reporting was that 99% of all the cases were mild. People didn't go to the hospital, they weren't very sick, they were recovering without incident. And this was reported in a number of databases, including by Johns Hopkins. And 1% of people who were getting really sick were mostly older or had prior chronic disease. And then we got this message even more emphatically. Remember the surge in Lombardy, Italy? That's the one that happened just before SARS-CoV-2 arrived here. Everybody remember that? And their health system was overwhelmed. We were thinking, basically, oh shit, it's coming. Is this what's going to happen to us? But in Lombardy, Italy, exact same epidemiology. Terrible toll among the elderly and chronically ill. Pretty bad toll among the elderly who were not chronically ill. Pretty bad toll among the chronically ill who were not elderly. And almost no adverse outcomes in people who were neither elderly nor chronically ill. And of course, we can't modify chronological age, but the chronically ill part was critically important. So we published these papers saying 6 out of 10 American adults have at least one of the diseases that's been recognized in Seoul and Lombardy as a major risk factor for a bad COVID outcome. We ought to be doing something about this. We ought to be modifying obesity, hypertension, inflammatory cytokines. We ought to be using lifestyle to do that, and we don't have time to waste. And 4 out of 10 American adults have at least 2 of these. The New York Times actually picked up one of our papers, and this ran where chronic health conditions and coronavirus could collide, and talked about the fact that hypertension, diabetes, coronary disease, pro-inflammatory conditions were going to make COVID outcomes worse. So did we do anything about this? Did anybody see the national Let's Get Healthy Together campaign as the first way to vaccinate against SARS-CoV-2? Anybody see that? That happened in your neighborhood? Let's have mobile units go around, give people masks if they want them, but also hand out fresh produce, healthy recipes, maybe even have masked aerobics instructors do block parties where everybody socially distances and exercise together. Any of that happen? Any of that good stuff? Anybody, anywhere. Zippo, nothing. I mean, there's absolutely no attention to the fact that we were mired in a prior pandemic of cardiometabolic disease that was making the acute infectious disease pandemic massively worse than it needed to be. Not a word, nothing. Zip, I don't get it. Anyway, the New York Times said these things could collide. And you'd think, okay, maybe we're going to do something about it. No, we just stood on the tracks. And these 2 New York Times articles, front page, are 2 years apart, where chronic health conditions and coronavirus could collide, May of 2020. And here we have April of 2022, COVID and diabetes colliding in a public health train wreck. We just stood on the tracks and let it run us the hell over. Everything I'm talking about that has been replicated innumerable times over 30 years was acutely relevant during the pandemic. But for some reason, something about our systemic thinking, something about the divide between the way we view disease care and actual health care created an impasse for us. The dots were never connected. We never said, hey, based on what we see in Lombardy, this is a really important time for communities, counties, states, the feds, employers, everybody to be sharing best practices to promote population-level health. And we can help everybody lose just a little bit of weight, reduce inflammatory markers, drop their blood pressure a little bit, improve their cardiometabolic health. If we could do that in a couple of months, it could make a huge difference. How huge a difference? We actually got that answer. This is, again, Dariush Mozaffarian at Tufts and his team, published in JAHA. They looked at the contribution of prior poor cardiometabolic health to the rate of hospitalization and mortality with COVID. And they did a computer model to say if we had reverted this cardiometabolic poor health, so type 2 diabetes, metabolic syndrome, coronary disease, et cetera, if we had reverted this to a healthy baseline, pre-pandemic, among all these same people, same age distribution, what would the impact have been on hospitalization and death? And their computer model centered, they did sensitivity analysis, all the usual stuff, but the point estimate was 60% reduction. 60% fewer hospitalizations and 60% less COVID death if we had done not a damn thing about the virus, but had only addressed our underlying health. Now, if we had done that and also done something specific about the virus, personal protection, vaccination, greater gain still, 60%. Almost not a word about this. This was a travesty. I hope you share my passion for this topic because we were distracted from the chronically important by the acutely important and failed to recognize the ineluctable bridge between the two. And this will come again. Not this particular pathogen, but the next one. Too many Homo sapiens in too many places blundering into ecosystems, exposing ourselves to zoonoses. It's going to come again. And if we haven't learned a damn thing from this one, it'll be as bad or worse. We've got to learn the lessons of this pandemic. This is among them. Lifestyle as medicine to promote general baseline health could have made a massive difference. 60% reduction in hospitalization and mortality, just that. And we're not talking about optimizing everything for everybody. We're just talking about fixing what really is fixable in the relatively short term. Diet quality measured objectively, directly associated with COVID outcomes. This was in BMJ Gut. So they used the Healthy Eating Index. The higher the score in large populations, the better the COVID outcomes matched for other variables. The lower the score, the worse the outcomes. I felt pretty lonely. I was ranting about this on television and in my writing. But I wasn't the only one. It was picked up in Politico, and others started to make some noise. But it hasn't influenced national policy at all, so far as I can tell. And if all of us rally around this issue, it could, in time, to do us good next time. Obesity, specifically, is a risk factor for bad COVID outcomes. It also appears to be a risk factor for long COVID, which, by the way, I think is essentially chronic fatigue syndrome, which is triggered by many other viruses. It's just that it was triggered by this particular virus in so many people all at the same time, it took on a legitimacy that chronic fatigue syndrome, encephalomyelitis has never had. But it's exactly the same condition. So it's basically an impairment of immune system function provoked by a viral exposure, probably involving some predisposing genes. There's a lot we don't know about it, but it's not unique to SARS-CoV-2. I did integrative medicine for 15 out of my 30 clinical years. We took care of hard-to-treat patients who'd been everywhere, done everything. And we probed deeply to understand these syndromes that people couldn't get fixed. And we routinely found a homogeneous cluster of viral exposures that were temporally associated with the onset of symptoms and symptom variation. So I think potentially this opens a door and it creates an opportunity to address what was a big public health issue before, much amplified by SARS-CoV-2. But obesity is a factor here. It seems to worsen the likelihood and severity of long COVID syndrome. And so it's very tempting to think that obesity should be targeted as a disease. And of course, we're seeing much more of that now with the advent of basically Ozempic in the drinking water, right? I mean, everybody's into the GLP analogs, and there are more of those drugs in the pipeline, some of them more powerful than Ozempic. I have a real problem with this. Again, it comes back to the fact that America runs on Dunkin' and we feed multicolored marshmallows to our kids, pour milk over it, and call it breakfast. Should we really be doing that and then putting everybody on pharmacotherapy and sending them for bariatric surgery? If we call obesity as a disease, which is done, I think, to legitimize it so we don't stigmatize it, so that we don't blame the victim, and I'm all for that. We should not be blaming the victim of obesity any more than we blame the victim of hypertension or coronary disease or diabetes. We could say all this stuff, or for that matter, getting injured in a car crash because you were driving 5 miles an hour over the speed limit. It's all your fault. But then, we wouldn't take care of anybody. We just blame the victims of everything and say, you probably provoked the shark who attacked you. All right? You know, you were probably wearing metallic clothes that attracted the lightning strike. It's all your fault. If you just stayed inside, the lightning wouldn't have hit you. So that's silly. Obesity should be on the same list as everything else. People don't choose to be obese. It is not the fault of the victim, which isn't to say there isn't a role for personal responsibility in doing something about it, but that's true of hypertension and diabetes and coronary. You have to take care of yourself. We all do. Nobody's going to carry us. But it's not the fault of the victim. So I'm totally on that side of the argument. But obesity is not a disease. The human body, taking in a surplus of calories and storing them against the advent of a rainy day, is the human body working as it should. What is not normal is that the rainy day never comes, that there's a constant surplus of hyperpalatable calories. And the danger in calling obesity a disease is we will only rely on pharmacotherapy and bariatric surgery and do nothing about the root causes. Is there another analogy that could work where we say obesity is medically legitimate, we don't blame the victim, we will take care of people who have this condition, but the primary focus should not be on dysfunction of the human body, but on causes in the environment, or at minimum, a human-environment interaction? Can anybody think of an analogy that's perfect for that? Because I've got one, and I've been talking about it for years. I don't think anybody's heard me except my mother. My mother loves it, by the way. Drowning. It's not abnormal for a human body to drown. We don't have gills. Stay underwater too long, you reliably drown. Nobody thinks that's a disease. Drowning is not a disease. But people don't blame the victims of drowning. Everybody accepts that drowning is medically legitimate. If you drown, we will resuscitate you and those bills will be paid. And our focus is not let everybody drown and then resuscitate them. Our focus is let's try not to let anybody drown in the first place. Let's teach kids to swim, put lifeguards at the beach, fences around pools, and remind parents to be vigilant when young kids are wandering near the water. We are drowning in willfully engineered hyperpalatable calories and labor-saving technology. And we could treat it exactly the way we do drowning in water. We treat it exactly the opposite, by the way. Were we to treat actual drowning the way we treat obesity, when there's a riptide and sharks in the water, Big Food would come along, put a sign on the beach that says, "Come on in, the water's fine." Right? So we actually actively encourage people and profit from people drowning in junk where food ought to be in labor-saving technology. Obesity is not a disease. This is an important issue to me. The disease is the food supply. Michael Moss is a Pulitzer Prize-winning investigative journalist, author of Salt, Sugar, Fat, and Hooked. He wrote this New York Times Magazine cover story, The Extraordinary Science of Addictive Junk Food. Anybody see this? Familiar? All major food companies, U.S., around the world, hire teams of scientists, give them functional MRI machines and marching orders to design, engineer food people can't stop eating until their arm gets tired from lifting it to their mouth. You're busy advising portion control to your patients. This is what they're up against. This is the disease. It's a social disease. Obesity is just a consequence of it. And this is why we need to address this at the level of culture. It is unfair to you to try and fix what teams of scientists are being paid bonuses to break in your patients. It's unfair. That's the job we've given ourselves. Fix this in the clinic as our entire culture rallies to break it for massive profit. This is what's going on. And we now know that this ultra-processing, which was clearly done to get people to eat more, works exactly as intended. There is a trifecta here of insights. So Michael Moss, Pulitzer Prize-winning investigative journalist. Carlos Montero, anybody know that name? The inventor of the NOVA classification that gave us basically an operational definition for ultra-processed food, University of Sao Paulo in Brazil. And Kevin Hall, anybody know that name? Researcher at the NIH, he famously does metabolic ward studies. You've probably read some of them, maybe this one, or at least heard about it in the press. So a randomized trial on a metabolic ward, foods, macronutrient thresholds exactly the same, but one diet was ultra-processed, one was not. Ultra-processing all by itself led to 500 extra calories a day and weight gain. Food companies know exactly what they're doing. We manipulate food this way, you will eat more, you'll run out faster, you'll be back to buy more, and that's swell. That's what's going on here, by design. So obesity is not a disease from my point of view, and I was privileged to be able to express that point of view in Nature, but it is a canary in the coal mine of chronic disease, and we must take it very seriously. Where there's more obesity, there is more heart disease, there is more diabetes, there is more dementia, there is more cancer. It's on the causal pathway to all the bad stuff that siphons years from lives and life from years. So as health professionals, I don't think we can be okay with the okay at any size movement unless people really are okay. We can encourage people to love the skin they're in, but it's our job to declare war on anything that is a threat to the health of our patients. And obesity all too often is. Not always. Some forms of obesity are metabolically innocuous, but most of the time obesity is causing metabolic mayhem. And that's not okay. Type 2 diabetes in kids is not okay. So we can be okay with the person who's dealing with the condition. Can't be okay with the condition because it's causing public health calamity. And again, I view obesity as a form of drowning. Do with that what you will. Wrote about that in Nature. I've written about it in multiple blogs. Doesn't seem to have caught on. But I think we should actually have ICD codes that say drowning A in water and drowning type B in junk food and energy-saving or sparing technology. And it would explain a lot. So again, we had an enormous opportunity. 2 pandemics are actually better than one. If SARS-CoV-2 had been a one-size-fits-all threat, if the virus itself took perfectly healthy people and threatened their lives routinely, all we could have done was what many of us wound up doing, hunkering in a bunker and waiting for vaccines. But if it was a very differential risk based on prior health status, then we could have altered prior health status, and we should have. So again, that get healthy together concept I think is really important. I published this early in the pandemic, this color-coded scheme, age across the top, health status along the side. The top left corner, that bright red cell A, those are very old people with long-established chronic disease. I'm not sure there was much to do there other than a firewall. So this gets us into policy discussions, and I won't take the time for that, but we could have done a much better job defending nursing homes from any exposure to this virus. And we knew we should after Lombardy. That was a huge mistake. So our defenses were too much for kids in school and not nearly enough for elderly, frail people in nursing homes. And so again, I'll avoid the politics and the policy, but most of these cells with lifestyle as medicine could have migrated to lower risk if we had focused on the opportunity to ameliorate chronic cardiometabolic conditions. And we just didn't. Certainly should have. Okay, enough about the pandemic. Let's talk planet, because our diets are cooking the planet. And so I want to revisit what I said at the start here. And if you disagree with me, you can not tell me, or you can confront me afterwards and tell me. But it's my view that we can no longer claim to be health professionals unless we are passionate advocates for the health of the planet. We have some hope of being healthy, vital people on a healthy, vital planet, or we have no hope of being healthy, vital people. It is in our purview. It is our job to talk about this. And it's our job to adapt what we say about other issues so that what we say is consistent with the needs of the planet. We don't have as many dietary choices as we once had. Sure, there was a time when we could have all been paleo, put on a loincloth, gotten a bow and arrow or a spear, and gone hunting for game. I actually did the math once in a Huffington Post piece. How much space would it take for 8 billion hungry Homo sapiens to live like roving hunter-gatherers lived, so that we're eating not factory-farmed meat, which has nothing to do with the kind of meat our ancestors ate, but actually eating the flesh of wild game? And my calculation, which used the average amount of space the literature tells us is required to live a forager lifestyle, for all of humanity to do that would require 15 times the surface area of the planet, including all the oceans, all the deserts, and the polar ice caps, every square inch, 15 times over. It's absurd. So we need to reconcile what we say about diet today with what's viable here, because we're not going to be healthy unless we've got a planet to call home. And our diet is cooking the planet. This was in the Atlantic. Essentially, diet is the main reason we're taking places like this and turning them into places like this, so they can be turned into places like this, so we can have more of this. Global demand for beef is the single leading driver of deforestation in the Amazon. You might have thought it was Brazil's crazy former president Bolsonaro. He did not help. But the profits from beef are the main reason the Amazon is being raised to create pasture land, to graze cattle, to feed the world's appetite for beef. We have met the enemy, and it is us in our carnivorous multitudes. And that doesn't mean beef is evil. If beef were raised to, in places where it's doing less environmental damage, if it were raised humanely, if it were raised at a level that were consistent with sustainability, there's no intrinsic evil. Animals eat other animals. We are native omnivores. But what we're doing to the planet is unconscionable, and we do risk bequeathing to our children and grandchildren a world that once had an Amazon rainforest. And in fact, we're hearing more and more, it's very near a tipping point, where the deforestation is such that the climate has changed, the production of water vapor from the trees has declined, the rain is stopping, and the trees that we haven't burned down ourselves are going to die off anyway. And the magnitude of this tragedy could scarcely be overstated. We don't have to do this, nor do we all have to be vegans, although it's a good thing, I think, if many people are, but we're constitutional omnivores, and minimally we've got choices to make, and I think every person of conscience should be aware that our dietary choices impact things like whether or not the world has an Amazon rainforest, and that eating less beef could make a difference, and that insisting that the beef that anybody does eat doesn't come from what used to be a stand of tropical rainforest in Brazil. We do have the opportunity for a grand confluence, and this is fortuitous. What we can do that's best for our health happens to be best for the health of the planet as well. We heard this in the Eat Lancet report. I trust you're all familiar with it. If not, I commend it to you. But here's a granular look at these issues courtesy of a group at Oxford University, multiple health and environmental impacts of food. I warned you earlier I had one eye chart and one only. Here it is. I won't linger on it. I'll just tell you this. Block A is human health outcomes, mortality, coronary disease, colorectal cancer, diabetes, stroke, and along the side there are foods, whole grains, fruits, vegetables, nuts, etc. And block B is all the same foods along the side and planetary health outcomes, acidification, eutrophication, greenhouse gas emission, land use, water use. This is a lot to take in and try to figure out. Don't bother. Happy to share the slides, by the way. But here's the summary. This is also from the same paper. So the lower left corner, low relative risk of mortality in people, low environmental impact, all the usual suspects cluster there. Vegetables, fruits, whole grains, legumes, nuts and seeds. Refined grains actually happens to be along for the ride. The upper right, again, the usual suspects, beef, red meat, processed meat. Bad for the planet and bad for people. And by the way, to be clear, this is not a moral judgment. We should not be talking about food in terms of good and evil. We should care about outcomes. That's what scientists do. This is amoral. There are moral implications of how we treat our fellow creatures. We could have a lengthy discussion about that. Suffice to say that if we get this right for people and planet, it will be kinder and gentler too. It's a Venn diagram. Dietary patterns best for human health. Dietary patterns best for the environment. And oh, by the way, kinder and gentler to our fellow creatures, which are not being raised in factory farms, because we don't need factory farms if we're not mass producing beef all around the world. So everybody wins. The wild places, the wild animals, the domestic animals, our aquifers. 'Tis a consummation devoutly to be wished. Lifestyle is the only kind of medicine I know that can help us get here. There are great groups working on this. You heard about Dr. Stahl's very important work, the Plantrition Project. There are recent developments in this space that I think are really important, so new organizations all the time. Dr. Sam Myers is an internist at Harvard, an environmental expert who founded the Planetary Health Alliance. Great book for anybody interested in all the details of why protecting nature protects human health. I commend this book to you. Myers and Frumkin, Planetary Health, Protecting Nature to Protect Ourselves. So it's all the direct links between planetary health and human health. Any dietitians in the room? It's all docs here. This is a really great effort because it's directed to dietitians. And of course, they collectively have a massive influence on what everybody believes to be true about diet. This was founded by a group of dietitians who've said we can no longer counsel about diet for human health as if planetary health were not at stake. We're going to educate about the confluence of the two so that we raise the awareness of dietitians. And their mission as an organization, this is a 501c3 nonprofit, is to train at least 1 million dietitians in the confluence of dietary patterns best for long-term human health and planetary health. So lots of great effort. And we're making one of our own. This is connected to what I do that I can't talk about, but I will simply say that I'm involved with intellectual property that includes a diet map. So we have diet type operationally defined on the x-axis, ranging from paleo and low-carb and keto at one side to whole food, plant exclusive at the other, and everything in between, Mediterranean, pescatarian, flexitarian, all the ethnic diets, and so forth. And then all of the diets are stratified into 10 tiers of quality using the Healthy Eating Index 2015, so low quality at the bottom, high quality at the top. Think about the diagonal from bottom left to upper right. You're going from animal food predominant bad diets to plant food exclusive good diets, massive environmental gradient. So we said we can quantify this. So we've been working on a project for the past couple of years called DIEM, as in Carpe Diem, because we need to seize the day, we're running out of time, but it's an acronym, it stands for Dietary Impacts on Environmental Measures. We're working with two world-leading experts, Guidon Echelle at Harvard, Marty Heller, formerly of University of Michigan, and what we've done is we've established quantitative scores for 4 components of environmental impact of foods: greenhouse gas emission, land use, water use, and nitrogen use. We've then aggregated the 4 into a composite overall environmental impact score for the food, and then aggregated from the food level to the overall dietary pattern level. And our work involves assessing what your diet is now and helping you find what you want it to be. And we are able to say, if you move your diet from the cell it's in to this cell, this cell, this cell, or this cell, here's the quantitative change and ideally reduction in the overall environmental impact of your dietary choice. Because we know not everybody's going to be vegan, and not everybody has to be, but everybody could improve. And we're hoping to reach millions of millennials who aren't yet worried about chronic disease, but care about the planet. So we call this DIEM, and we'll be rolling this out as an app probably by the end of 2023 or at the latest in early 2024. A quantitative measure of how dietary change impacts overall environmental measures. The DIEM project. Just quickly, I've left myself only a few minutes. I want to say a couple of things about how we know what we know, since my mission was to talk about evidence. So I did a debate with someone I won't mention on what we know about lifestyle medicine, plant-based nutrition, and so forth. And one of the things I did during this debate was toss an apple in the air, and it floated back down to my hand, quite predictably. And yet, I had no research evidence to back up that that would occur. I was confident of it. I caught the apple. No research evidence. Sometimes correlation is causation. It really is. There's a great book on that topic by one of the founding fathers of AI, by the way, Judea Pearl. It's called The Book of Why. If you doubt that correlation can be causation, like the fact that if we toss an apple in the air, it will come back down, that's cause and effect. Put your hand in a fire, it will get burned, cause and effect, no randomized trial required. I recommend The Book of Why. My wife and I have raised 5 kids to adulthood. We always took a strong stand against running with scissors, even though I have never read an RCT on the topic. We were pretty adamant about looking both ways before crossing a busy street, too, even though I've never seen a meta-analysis on that topic. We need to recognize that a lot of what we humans know that matter most, we know from simple observation and the consistency of patterns. Really important. Now, I say this as someone who has conducted and published dozens of RCTs. I'm a fan. They answer certain questions. But we need to use the right method to answer the question we have. In lifestyle medicine, we care about longevity and vitality. We're going to get more of that information from blue zones-like projects than we're going to get from RCTs, and then we can combine the two. Combining the two is the trick. So colleagues and I published this paper, Hierarchies of Evidence Applied to Lifestyle Medicine. This is an alternative to GRADE. This is an evidence synthesis method that's now being used when the interest is years in life, life in years, and it basically argues that we can construct high-quality evidence from different sources. We can use RCTs to get at attribution in the short term, but we need observational epidemiology to tell us impact at scale in the long term, and on it goes. You get the idea. But if we want to be able to speak to one another in terms of evidence, we need to make sure we align the evidence to the questions we're posing. And an RCT is not always the best tool. Anybody do carpentry? I'm a fair to middling carpenter. I've got a great wood shop. I've got no tool that can do what every other tool does. I need a whole array of tools. A hammer's a great hammer. It's a shitty saw. A saw's a good saw. It's a bad screwdriver, and on it goes. Same thing with research methods. There is no one method that's best suited to answer every question. We need to respect that. We're being talked into a tyranny of evidence that only RCTs, which were largely designed for pharmacoepidemiology, can answer questions about diet. There is no placebo diet. You can't blind people to what they're eating, and you can't do RCTs that last 100 years. We're going to need to use other sources of evidence too. Mechanistic studies and RCTs and observational epidemiology, and combine them artfully, and then we know what's what. And we can work in accord with the weight of evidence. We did a spread on this in the American Journal of Health Promotion, dietary research done right. This is public access, so help yourself. So my name, dietary research done right, and again, a whole group of authors here, Walter Willett at Harvard, Christopher Gardner at Stanford, who's a member of the Dietary Guidelines Advisory Committee, and many other august colleagues were involved. Help yourselves. And then finally, another important issue we have to wrestle with. There was a time when we knew that blood pressure was really important, but nobody knew their blood pressure. It was the world before the invention of the sphygmomanometer. We already knew blood pressure was associated with heart attack, stroke, blindness, kidney failure, but nobody knew what their blood pressure was. So we just waited until you had a heart attack or stroke, and then we knew your blood pressure probably wasn't good. That was the world before the blood pressure cuff was invented and socialized. It is the world we are in now with diet. So we know that our food is killing too many of us. Single leading predictor variable for all-cause mortality, total chronic disease, is diet quality measured objectively. How many of you have had your diet quality measured objectively? Completed a food frequency questionnaire, done a multi-day food journal, submitted to a dietitian for analysis? One? No, not even one. One. Two. Yeah, hardly anybody, right? Predictably. And with good reason. Those things are mind-numbing. They make your eyeballs melt out of your head. It's horrible, right? So, it was like the days when, yeah, you can have your blood pressure checked. It's an intra-arterial catheter. Who's going to sign up for that, right? You only do that if you need it in the ICU. Okay, that's where we are. So we know that we had this op-ed telling us our food is killing too many of us. Within less than a year, the American Heart Association took the formal position that diet quality is so important, it should be measured in every clinical encounter, if only we had a tool to do that. And I'll simply say that this phase of my career is devoted to that enterprise, and so you can track me down and we can talk more about that. But our advance basically argues, this is in the peer-reviewed literature, dietary assessment can be based on pattern recognition rather than recall. We don't have to ask people to badly misremember how many broccoli florets and donuts they ate in the past 6 months. We can create assemblies of overall dietary patterns and say, which of these looks more like how you eat A or B, play a 60-second game, and get to the same answer. So more about that for those of you who have interest. Final consideration before we wrap this up is the issue of profit. If we're going to peddle lifestyle as medicine, food as medicine effectively, we need for this to make good economic sense, and fortunately it does. Diet quality in particular is upstream of biomarkers we know really matter, which in turn are upstream of incident and prevalent chronic disease. What we know is that the average annual per capita costs of those chronic diseases are high. Obesity versus not, an extra $2,000 a year on average. Hypertension versus not, an extra $2,500 a year on average. Type 2 diabetes versus not, an extra $10,000 a year in medical expenditure on average. Coronary disease versus not, an extra $25,000 a year on average. You alter these variables at the population level even a little bit, you're talking about massive savings. And that money can go to pay for the programming that alters these variables more than just a little bit. So what we've done, using our ability to measure diet quality objectively very readily, we published a paper on the financial case for food as medicine and introduced an ROI calculator. This ROI calculator is in the public domain, so if you check out this paper, you can help yourselves to it. If you're doing pop health, or you're wondering what would happen to the outcomes in my patients and what would it mean for the bottom line in a value-based care setting if we were to improve diet quality 1 decile, 1 quintile using the Healthy Eating Index, this will answer that question. The calculator is pre-populated with the prevailing epidemiology of the United States, but you can put in whatever numbers you've got. If you're doing pop health and you know the prevalence of obesity, hypertension, diabetes in your population, you substitute those numbers, we'll generate an answer. And what I can tell you is it's really gratifying. Significant financial benefit even within that critical first fiscal year. Food as medicine is good business. And there's more and more attention to that and trials of this in Medicaid and Medicare Advantage. So I think it will be a new day when instead of giving people junk where food ought to be to make them sick and then drugs to treat the diseases they didn't need to get, we will be seeing much more food as medicine to prevent those diseases in the first place. That's a really good thing. And we're starting to see studies that are looking at this from altitude, like this one, Food as Medicine, Exploring the Impact on Adherence, Clinical and Economic Outcomes. This was basically a nationwide assessment with the conclusion that food as medicine used routinely would save up to $50 billion a year on medical expenditure. So this is basically just aggregating some of those numbers I was just talking about to the population level. And we've already known and reaffirmed recently that adherence to any of the healthy eating patterns is associated with significant reductions in total chronic disease burden, all-cause mortality. This is a shot of the interactive calculator. It's a web page. Again, this is freely available to all. Help yourselves. If you have any trouble finding it, please let me know. And that brings us to the end and the promise of all of this. For a very long time as clinicians, we've had the weight of our patients' health problems to deal with, their weight, their cardiometabolic health, and Lifestyle as Medicine offered tremendous promise to address that. We have failed to realize the promise of that because all too much has been lost in lack of translation, turning what we know quite reliably into what we do routinely. We now have an even greater reason to turn that knowledge we've long had into the power of routine action, because it's not just the weight of patient care and those responsibilities, it's the literal weight of the world. Make no mistake, if we are effective both clinically and culturally at turning diet and lifestyle into the medicine they ought to be at scale, we have hope of being healthy, vital people on a healthy, vital planet. Thank you all very much.
Okay, so now we're actually going to start a Q&A with Dr. Katz. And I actually had an interesting thought. When you were mentioning, a lot of your research was by Dean Ornish, and the research you quoted, and you had mentioned a few things about inflammation there. I know I've read very recently, probably with, I think this winter it came out, was the New Unified Theory of Lifestyle Medicine, published by David Katz in the American Journal of Lifestyle Medicine. This totally brings in together everything we've been learning at this conference. It brings together, we had Dr. Olson talk to us this morning about orthopedic surgery and inflammation. We had Dr. Scott Stoll talk to us about inflammation. Oh, are we loud? Is that better? Okay, I'm sorry. And we've had so many speakers talk to us about that inflammatory process, which it perpetuates all these chronic diseases. And so I think, and I actually mentioned that in my most recent paper that I published in the American Journal of Lifestyle Medicine too. And so I feel that's, do you have a comment about the new theory of lifestyle medicine?
So colleagues and I, in particular a group at UPenn, Yoram Boldovitz and others, we actually have a paper in press at Frontiers in Public Health now on inflammation as not just a unifying issue in lifestyle medicine, but essentially a multi-tiered view of inflammation. You could argue that the world is inflamed. The planet's clearly inflamed, and there are good cartoons that joke about that. The planet's the patient, and the doctor's saying, "I've got really bad news. You've got humans." So we are the inflammatory plague, and the planet's inflamed, and it's heating up. It's as if it's got a fever. It all fits. But we are inflamed as a society, right? The divisions that were exacerbated by politics over recent years, the pandemic, the inability to have civil discourse, to disagree and find common cause on common ground. It's inflammatory. And then the more inflammatory we become, the more it actually inflames not just our inner cells, because we're more stressed, and it's very clear that affects the adrenal pituitary axis, cortisol levels, counter-regulatory hormones. The mechanisms of this are clear. So when we talk about stress and inflammation, psychology and inflammation, this is not abstract. We know the mechanistic pathways, the endocrine pathways that are involved here. But if we're stressed about the state of the world, anybody stressed about the state of the world? I'm stressed about the state of the world every damn day. I'm stressed every day. Well, it's inflammatory. And, I do a lot of things to try and mitigate that, but what I haven't figured out how to do is address that one at the source and have a less inflamed, more civil world. But I think that's inflammatory. And then the more inflamed we are, the more we inflame one another. That's what internet echo chambers do. We find other people whose passions are inflamed in the same basic direction as ours. We egg one another on, and we amplify that inflammation. There's a great book on that topic by Thaler and Sunstein called Going to Extremes. Cass Sunstein was a policy advisor to Obama and I believe Clinton before him. But essentially they were interested in explaining radical behavior among terrorists. But then they extend the discussion to radicalization of all of us in echo chambers. Anytime we find people who hold the views we hold and get together with them, those views become increasingly more extreme, and we lose the ability to find common cause and common ground with anyone else. So in this paper, we actually talk about the issues of inflammation from the intracellular level, where we know how they're affecting mitochondrial function, we know how they're affecting DNA function, we know how they're affecting the epigenome, we know how they affect mitochondrial, chromosomal structure, length of telomeres, all the way up not just to the individual, but all of society, where essentially we're inflamed. And it arguably is one single continuum. And so that last issue that's easy to overlook on the list of critical lifestyle medicine considerations, social connection, love, it's not just about our intimate circle of friends and family and love. It really is about cultivating a sense of community where we can get outside of these echo chambers, we can talk to one another. Of course, I don't know the answer to that, and we now have a new acute threat in that space with AI, which has the potential to take all of divisive propaganda we're already exposed to and put it on steroids. The worry. The likelihood that we're going to find ourselves subject to a world of terminators anytime soon is extremely remote. But the likelihood that anybody, anywhere can produce extremely effective, highly influential propaganda, that's not at all remote. And so the wedge just goes in wider and wider. That's inflammatory, and that really worries me. So yes, I think it is a unifying theory, and I think lifestyle medicine has something to offer across that full expanse. But I think some of our biggest problems are not just intrapersonal and addressing health there, interpersonal, intercommunal. And I don't know, just as I don't think we can be healthy, vital people unless we have a healthy, vital planet, I'm not sure we can be healthy, vital people unless we can talk to one another. We need those social connections. They've got to last, they've got to stick, they've got to be healthy. And we've been squandering that over recent years. It disturbs me deeply.
Thank you for that.
Yeah. Your answer actually covers a lot of my comments or my questions, and that is the politics and the laws that can help a doctor to translate the information that we have into actual societal general applications, which I think was, like we had with cigarettes, we had the information, and eventually the doctors were able to, implement it, but then politics and the legal system stepped in, and then that made a big impact. I feel like right now, one of the frustrations that you had expressed was that we have the information, and it's in the early stages, but there's no politics or laws that really support the doctors who are interested in making these bigger shifts in society,
So, yeah, it's a great point, a point of frustration we share. It is changing. It's changing in terms of certainly food as medicine, where there actually is a lot of money and a lot of legislation backing up at least pilot programming paid for by third-party payers, because we do have a critical mass of evidence. And these things obviously come full circle, right? You can't do something if you don't have evidence to suggest it's likely to be a benefit. But it's hard to generate the evidence to show that something works if nobody's doing it. So we tend to get hung up at these impasses, and it can take a long time to work against the currents of our culture, aggregate the evidence, and say we have enough to give this a try, start to scale it up, start to do it more intensively, start to do it better. I think we have enough, and I think we're starting to see widespread experimentation in this space. The Rockefeller Foundation and the American Heart Association are partnering and making a major national investment in food as medicine programming. And yes, this should extend across the full expanse of lifestyle, but there's more and more of that. There's still an awful lot of resistance. One of the critical issues, so I mentioned only very briefly this paper, Hierarchies of Evidence, really important to me. So we built a new method of aggregating evidence. We called it evidence threshold pathway mapping. But the idea that you can only base decision-making on RCTs is egregiously flawed. And so one of the organizations that, as a preventive medicine specialist, I've been taught to revere, yes, they provide a lot of good guidance, but they're also quite constraining, is the U.S. Preventive Services Task Force. So as I trust you all know, they address clinical preventive services. They're massively influential. They influence congressional legislation directly all the time. So, basically they reach a conclusion. Something gets an A grade from the U.S. Preventive Services Task Force, it's very likely to translate into policy. The problem is, anybody who's familiar with this, you guys all know the U.S. Preventive Services Task Force, right? Clinical Preventive Services. More often than not, it's not A and it's not D. There is insufficient evidence to conclude just about any damn thing, right? We can't say if it's good. So it's not evidence of absence, it's just absence of evidence. But the specific absence of evidence they're talking about is RCTs. We're never going to have RCTs to answer the question, does eating optimally add to longevity? Does eating optimally help prevent every major chronic disease? You can't get that answer from RCTs. There was an effort at the CDC to try and address this with something called the Community Guide, which was looking at alternative forms of evidence for population-based interventions. Sadly, the Community Guide never had the political influence of the Preventive Services Task Force. But I'm totally with you, and I would argue we actually do have the evidence. It's just not all packaged in RCTs. And if we bundle across the different sources of evidence that are readily available to us, we can make the argument right now that lifestyle intervention deserves to be mainstream, that it ought to be taught more widely. We're seeing this happen slowly anyway, so I think eventually we win the day. And it also helps our case that the current economic models are clearly not viable. Sure, it's great that the GLP analogs are really good for weight loss, but do we really want everybody in the country? 70% of adults are overweight or obese. Do we want everybody on pharmacotherapy? We're going to put Ozempic in the drinking water? The cost of that is massive, to say nothing of the potential for side effects and so forth. So there are a lot of economic forces on our side, and ultimately politics and economics wind up in bed together. So if the economics are shifting in our favor, the politics will too. But I agree with you. I think in some ways it's a complex story where we have stipulated certain arbitrary standards of evidence that pertain to some questions in medicine but not to all. We look to that kind of evidence to answer questions about what we should and shouldn't do, what we should and shouldn't pay for, and wind up being forestalled in other areas where there's a tremendous opportunity to do good. But there is progress being made in spite of all of that.
Thank you. My question is a bit sophomoric, I bet, but I'm thinking, as we're listening to all this really horrific data, my thought kept going to how in the world do you do anything? And the one thing that I thought of that I saw someone do was when the mayor of New York put a tax on sweetened beverages in the city. I'm not a population health guy. I'm curious if you know if that shifted the needle at all, and if you have any actual ideas beyond something like a use tax to actually get people to make any changes here.
Yeah, really good point. So yes, Eric Adams is a proponent of that. Bloomberg, I think, is the administration you're talking about. Actually, the best evidence for taxes as a public health contribution, leaving aside tobacco, but in the area of food, comes from Mexico. There have been population-wide experimentation with soda taxes in Mexico that have reduced sales of soda, reduced consumption, and also translated into some key public health metrics. So yes, it works. But no, it's not the only way. So there's a whole field, as you know, of behavioral economics, and it's not just about the stick, it's also about the carrot. I mean, I told you, I think early on, I'm an equestrian, so I know intimately carrots are much nicer. My horses love carrots, rarely use the stick. So if you can do this with incentives rather than disincentives, I've done some work in that area. We developed a nutrient profiling system at my shop at Yale years ago. We wanted to connect a score of nutritional quality of individual foods to financial incentives and deploy that in the SNAP program. So the more nutritious the food, the less it costs you, and the savings go into a savings account that you can use for education, clothes, just about anything except tobacco, alcohol, or junk food. I think there are lots of different ways to leverage the carrot. The other thing that we can do is put a better gloss on the value proposition. And I think each of us as individual clinicians can do this. So you mentioned that the data are horrific, right? So this can become a very depressing story. Depressing about public health, depressing about planetary health. But we don't have to tell it that way. We could talk about the world we could live in, where everything is sustainable, where everybody's dietary choices are ideal for the health of the people they love, and much gentler for the planet, where we can be confident that there's going to be plenty of water and good food available for the next generation and the next and the next. We're thinking about, even selfishly, just the people we'll know, our grandchildren, our great-grandchildren maybe. There's also another element to all of this I didn't talk about. My wife is French, and she's a brilliant cook, and we've worked together on many programs over the years. The tagline to her free recipe site, Cuisinicity, is, "Love the food that loves you back." There's a real opportunity to do that. The average American palate has been egregiously corrupted by junk where food ought to be, and people like eating junk because they're used to eating junk. Taste buds are adaptable little fellas. They learn to love the foods they're with. There are many studies, to say nothing of our individual clinical efforts, that demonstrate if you start to reform diet and take just a little bit of time, your taste buds adapt. You eat less and less sugar, they prefer less and less sugar. You eat less and less salt, they prefer less and less salt. And you come to actually develop aversions to junk and prefer wholesome food. So I think we're talking about how would you like to live in a world where you and your family are effectively immunized against all the bad diseases that take years from people's lives and life from people's years, and do it in a way where you can choose a variant on the theme of eating well that doesn't cost you more, by the way, and I won't take the time to elaborate the data there, but there are data there. Because, I mean, just as a quick, for instance, beans are a lot less expensive than beef. Water is less expensive than soda. Yes, some healthy foods are more expensive. Many healthy foods are less expensive. It's a wash. You can eat better without spending more. So you don't have to spend more money. Your taste buds, if you take 6 to 12 weeks to let them adapt, they will appreciate these more wholesome foods. Not the very first time you eat them, but we'll get there incrementally. We'll help you do that. And then you spend the rest of your life loving food that loves you back, loves your family back, loves the planet back. I mean, what is there not to like, right? So the news is not all doom and gloom. And I think there's a lot that we can do. And it's partly a matter of us using emotional intelligence to figure out what is it I need to say to a given patient that will motivate them? How do I use motivational interviewing? And then how can I apply this at the pop health level too, so people, A, understand the value proposition, feel inspiration, think about personal aspiration, and wind up being fairly outraged at the status quo, which is putting a lot of highly profitable junk where food ought to be, stripping away opportunities for physical activity, and ravaging both human health and the planet. Why should anybody favor that approach, right? So I'm hopeful. I think there's a lot we can do.
Is there any example of a community anywhere in the world
That's done this?
that's done this? Yes.
There are several. So homegrown, Christina Economos at Tufts ran a project in Somerville, Massachusetts called Shape Up Somerville. It was focused on kids and childhood obesity, but it did all this. It basically unified the work of the retail community, business leaders, politicians, parents, and civic leaders, and bent the curve. So actually declines in rates of childhood obesity while they're going up everywhere else. There's the Stanford 5-City Project, which is a somewhat old vintage. There are the Blue Zones projects, which are expressly commercial efforts, largely funded through insurers, trying to take the community, the cultural advantages of the Blue Zones and turn them into community-wide change at various locations in the US. They're having good results. But the single best answer to your question is North Korea. The North Korea project. So one of the heirs apparent to the work of Ansel Keys in the middle of the 20th century was a guy named Pekka Puska. And Puska said, well, you know, in my region in Finland, we have the highest rates of death from coronary disease at very young age anywhere in the world. So I wonder if we could take what we know about the dangers of excess saturated fat and excess animal foods and do a community-wide intervention and do something about that. The North Karelia Project was born. It runs to this day, so it's been running for well over half a century. A guy named Erkki Vartiainen runs it now, and they've been publishing on the results. They reduced mortality from heart disease in North Karelia with a community-wide intervention, doing everything we're talking about. So all the stakeholders were involved. It's not just clinical, it's clinical and cultural. Over an 80% reduction in cardiac mortality and incident coronary disease, dramatic reductions. Now, cardiac mortality has come down in the rest of the world because of interventions too, but they're way ahead of the curve. So a massive population level effect, but not just because of clinicians, because there basically was a community-wide effort to say, let's transform the culture. Sadly, people got so used to the benefits of what North Karelia was doing, the new generation is starting to doubt the benefits of all the intervention components. They're going back to some of the old ways, and rates of heart disease have started to creep back up. So yes, it is doable at the population level. It's been done.
So question, a lot of us in this room take care of patients who live in poverty and live on a fixed income. And a lot of the foods that have been talked about in this conference, fresh fruits and vegetables and so forth, not only might not be affordable, but also might not be practical.
Accessible.
Or accessible. Food pantries are full of canned goods. That's what we donate. So I guess the question is specifically about canned goods, maybe specifically canned vegetables. Any studies out there that look at how good that is compared to fresh fruits and vegetables as a good alternative? What do you think of that?
Great question. So important. And yes, there's good evidence comparing nutrient composition directly. The only key issue to think about is what else is in the can, right? So you may have, like broccoli in a can in a heavy cream sauce, and it's really a can of heavy cream sauce with a little bit of broccoli. That's a problem. But you're talking about actual canned beans, lentils, sometimes grains, certainly vegetables, sometimes fruits, and often they're packed just in water, sometimes water and salt. The excess salt can easily be rinsed off, so you pour out the can and stuff. Nutrient composition is almost exactly the same. So immediate canning actually does a really great job of preserving nutritional value. One of the issues with fresh produce is, it's fresh, but it had to get to us from somewhere. And sometimes those journeys are long. And there actually can be a significant degradation in select nutrients. Some of the very ones that Scott Stahl was talking about, some of the key antioxidants, degrade with time on a train or time on a barge or wherever these things are. And actually canning at the time of harvest, so right at the point of harvest, preserves nutrient value even better than in fresh. The same is true of frozen. Most of the produce in frozen foods is flash frozen very soon after being harvested with near perfect preservation of nutrient quality. I think we could argue it may not taste as good, right? Frozen vegetables tend not to taste as good as fresh vegetables. So there are many arguments on the culinary side for fresh vegetables if you can. And you're right, the problem isn't just affordability, it's access. If you have the access, though, through farmers markets and others, there are lots of great programs, Wholesome Wave, others, that incentivize SNAP beneficiaries and others to better be able to afford fresh produce. But this issue of affordability, it's something of an urban legend because, yes, fresh produce is pricey. But a lot of the stuff people eat is much more expensive than the stuff they don't. And the stuff they don't eat is much better for them. So, beans and grains, extremely inexpensive, highly nutritious. There's no question, if people had the right culinary literacy and the right food label literacy, we could massively improve diet quality without people spending more money. Access is a different issue. But yes, canned goods, the only thing to really be concerned about, so when you're talking to your patients, is just, look at what else is in the can. But if it's just water or water and salt, just rinse off the extra salt, but it's great. Nutritionally, just the same.
Thank you so much for your presentation. We enjoyed it. And actually, I am from the Middle East. For the last few years, I am here in America. So there is a kind of believing among the people in the Middle East that healthy food, it means not delicious food. And many of them, they persuaded that healthy is much better for them, but they say that we cannot give up because it is not delicious. So my question to you is are there a kind of studies or research to address this issue? How we can make this healthy food more delicious, or at least such as delicious of actually not healthy food? And do you think that we can find one time, for example, here, to see such restaurants instead of McDonald's, or addition to McDonald's, Health Donald's restaurant here, for example? Thanks.
Yes, so great point. And yes to all of that. I don't know whether this is supposed to be secret or not, but John Mackey, the CEO of Whole Foods, is involved in a project to try and do something like that, healthy fast food. Others have been in that business. You could argue Chipotle is to some extent involved in that effort. I think it would be really wonderful to see that with specific regard to Middle Eastern food in the U.S. But the answer to your question is yes. There are actually studies that look at, first of all, can you combine delicious and nutritious? Some of the best efforts are outside the direct research realm. So Culinary Institute of America, menus of change. That's what it's all about. It's about culinary experts, people who are interested in Michelin stars. So they're all about delicious, learning from one another ways to optimize nutrition. The person that I know best who's absolutely brilliant at this is my wife. So as I mentioned, my wife is a French foodie and a great cook. She also has a PhD in neuroscience from Princeton. But after we had a bunch of kids, she stopped doing neuroscience. She said, I'm going to use my scientific acumen. I'm going to do this. I'm going to reformulate traditional recipes in our kitchen, changing one variable at a time to maximize nutrition, but I will not give up on delicious. I'm a foodie. And so Cuisinicity, it's my wife's website. All those recipes are freely available to all, so like Cuisine City, but with an I in the middle. Cuisinicity.com, help yourself. Organizations that are looking at this very issue, how can we meet people where they are culturally and help optimize nutrition? We do that at my company, where I told you we have lots of different ethnic diets stratified into all the different tiers of quality. So if you are Lebanese, you're from some other country in the Middle East, that's the way you want to eat. We say, sure, let's look at an optimal version of that diet. So you don't have to go outside your lane. How can we combine delicious and nutritious, keep the overall pattern familiar? An organization that does great work there is Old Ways. You're familiar with Old Ways? Old Ways is a nonprofit organization, so just Google Old Ways, Health Through Heritage. They've actually created food guide pyramids for different cultures all around the world and say, this is not a one-size-fits-all. People should love the food that loves them back. So I don't think that's daunting. And, obviously people who are eating lots of highly processed junk food, they need to be weaned off it, and they need to go through taste bud rehab. But taste bud rehab is very achievable. So we need to explain that to people, help coach them through that. But I do think we need to meet them where they are. And frankly, there's lots of really great choices for health in most Middle Eastern cuisines. One of my favorite cuisines on the planet. I eat that way all the time. So you can stay within the familiar and still optimize. And I think that's how we get better traction. I should just do maybe one more question, and then we'll move to the next venue.
Great. It's two parts, so you can pick one if you'd like.
Okay.
First part is, will you comment on the one graph slide when it comes to olive oil and the discrepancy between singular health versus environmental health? The second, wine at 5 part of the blue zones, where it is known to interfere with gut health microbiome and yet has good compounds, resveratrol, etc. I understand it's not part of the Seventh-day Adventist group, but all the other blue zones have that alcohol as a part of the overlapping background of what they do. So if you would speak to that as well.
Okay. So the first question is, I'll get to this if I can get here quickly. There we go. I actually, this came up, I gave a talk in Savannah, Georgia earlier this week. This question came up. So olive oil looks like it's not quite in the happy place you'd like it to be on this slide, right? So keep in mind that oil is intensive food production, right? You have to, first of all, you need an olive tree. Olive trees are thirsty, and they grow in some thirsty parts of the world. So the water cost of producing olives is relatively high, as it is for almonds. That doesn't mean they're bad foods. It doesn't mean we shouldn't eat them. But just, if you look at a comprehensive scale for all foods, olive trees are somewhat thirsty. They're not as thirsty as almond trees, but they need a lot of water. And it takes a lot of olives to produce olive oil because you're just pressing out essentially one extract from the overall fruit, and you're discarding the rest of the fruit, right? So it's labor intensive, it's cost intensive. But the relevant question here is not, is olive oil as good for the health of the planet as vegetables? The relevant question is, how does olive oil compare to other oils? So if you're going to include extracted oil in your diet at all, which are the most sustainable, best for human health? And olive oil outperforms most others. There are other good contenders, by the way. High omega-3 canola oil is very good. It's good environmentally, excellent for health. There's actually a form of soy oil that's high in omega-3, has an excellent distribution of fatty acids. So it's not olive oil is not the only one by any means, but it's excellent. So it's compared to what is the relevant question here, and I didn't get into that, but you could and say, so olive oil, if you're going to add oil to your diet, it's an excellent choice. Does it have a higher environmental impact, or is it as good for human health as eating spinach? No, right? And that makes sense, and the amount of your diet you allocate to extracted oil is going to be a lot less than the volume of your diet you allocate to vegetables, fruits, grains, legumes, right? So it's a smaller contributor. But that's why olive oil appears where it is. On the issue of alcohol, I'm not sure what to say, except that obviously it's psychoactive, and it has social functions as well. So I think if we isolate specific and by the way, it has some beneficial biochemical effects. So if we just think about metabolic processing of ethanol, it does bump up HDL. It does bump up endogenous TPA. So it has antithrombotic effects. We know that it makes platelets less sticky. It just does. Now, the net effect of that on heart disease outcomes somewhat debatable, but there are mechanisms for potential benefit there. But if it's shared communally, if it's part, if it's a social lubricant, if it eases social interactions so they're more meaningful, that rosy glow of, a little bit of alcohol included in the meal, if it enhances pleasure, those things, the physiologic benefits of that, the epidemiologic benefits, they're hard to measure, but they're probably real. So yeah, the Blue Zone, certainly in Sardinia and Ikaria, they drink red wine. So some of the benefit may be the benefit of the antioxidants in the grape skins that they get in the red wine. Some of the benefit may be HDL and endogenous TPA. Some of the benefit may be social lubrication. Some of the benefit may be pleasure, and some of the benefit may not be benefit. It may simply be that their overall cluster of lifestyle is so potent a medicine that a small detrimental effect of the alcohol is massively superseded by the net effect of everything else they're doing, right? So it could still be a little bit harmful and not show up as net harm because overall what they're doing is so good. We don't know. It's really hard to isolate those effects. But I think there are arguments to say that alcohol could be contributing some net benefit. It's clearly not contributing enough net harm to undo all the rest. So if you like a glass of wine with your dinner from time to time, if you're asking me whether or not it's okay, I think it's okay. I like a glass of wine with my dinner from time to time too. Folks, it's been a great pleasure. Thank you very much.